The other day I was in the emergency room and we had a fellow in from one of the residences in town. And we know from experience that this particular residence tends to have a transient population. That is, they tend to be economically disadvantaged, people who live there. So we kind of know that already, and we've had discussions as a organization here at the North Perth Family Health Team with that organization, and have offered to make sure all of them receive primary care as they come in and out of town. So that's one way we've dealt with the poverty issue. So when this fellow came into the emergency room short of breath, I suspected it already, and that would be an example of where you would ask the screening question, do you have trouble making ends meet when you get near the end of the month? Are there financial issues for you as you get near the end of the check? And certainly this fellow who was short of breath did respond positively to that. And I know at that point that this person is at risk for a number of various health problems, including he's more likely to have heart disease, for example, and in the context of shortness of breath, where clinically it looked like someone with COPD or emphysema. You have to, it broadens your concern a little bit that something else might be going on with them. And it brings up the whole issue for this particular fellow of not only is he accessing all of the appropriate financial resources that he could, which is part of the conversation, and I'll admit that it's difficult as a physician to know what those resources are, but it brings up the conversation, and it makes it more likely that he will have trouble buying any prescriptions or engaging in any kind of therapy that I suggest, which actually turned out to be the case in this particular example. He has COPD, he's been prescribed puffers over time, and he doesn't have any. He can't afford them. He still smokes, and there is money going that way. So we were able to have the discussion about resources, and I was able to get him some samples of prescriptions, and now it turns to kind of working with him to through the primary care sphere to help him access those resources. So this is where HealthLinks comes in, because in my mind, if you've identified somebody with poverty, which is something like 20% of the population, then there's a lot of work to do to support these people. And the HealthLinks initiative here in Perth is a great way to support patients as they go through the care planning process. Dr. Narayan, the internal medicine specialist from Stratford, and I went through the list of quality-based procedures for heart failure and COPD, and came up with something like 15 of these bundles, or these quality care pieces that could be put into a bundle. So why do we use the word bundle? So from the intensive care world, they introduced the concept of bundles. So there's a number of things you can do in an intensive care room that would make care better. And they realized that if they gave the list of 30 things to the team, it was a bit overwhelming and people weren't engaged and it was difficult to do. What they found though is if they picked 5 and said, we're going to do all 5 and see how many patients get all 5 or don't. So it's a yes or no to 5 things. That after time, they actually were doing all 30. And so it's a way of biting off a piece of best evidence care, concentrating on those pieces, and then in the end you end up doing sort of a better, higher quality job overall. I would encourage the teams who are looking at quality improvement from using the HealthLinks platform to pick 5 things, and then over the next few care conferences where the diagnosis of CHF or COPD is involved, which usually is, how many times did you discuss all 5 things? How many times did you not? And why not? And what can you do to improve that particular rate? So pick a bundle from the quality-based procedure list that Dr. Narayan and I have made up, and put it to use. And in that, definitely add the poverty screen, because it's a it should be there anyway, to be honest. I think the HealthLinks are onto this in our region, and that's one that's already there. So that could be one of the 5 things your group picks. What's really interesting for me is what you do with the information once it's positive, and do you really feel like you are supporting people who are impoverished in sort of getting the best evidence care that they can get. My message to primary caregivers is be involved in those care conferences for your sickest patients, and make sure that the best evidence care is supporting the patient and their goals, which are usually things like staying home and feeling symptom-free.